Now I would like to invite the Terminator, Dr. Rajendra Prasad, and he will be. Okay. And he will be presenting on IOL gone wrong. How do I manage surgical pulse?
So good evening, and chairpersons and dear friends. My topic is I'm going to talk on a few case series on IOL gone wrong and the pearls of management. It's not coming to the. No, but it has to come this. Yeah, bring it to this full. I need the full presentation. It's full screen. It's not coming full screen. नहीं है, आ जाएगा. प्रेजेंटर व्यू में नहीं आ रहा है. नहीं, प्रेजेंटर भी इसमें करो ना, फुल स्क्रीन में. फुल स्क्रीन क्यों नहीं चल रहा है? ये है ना, ये चल रहा था मेरे उसमें. दोबारा लगा के देखो इसमें. प्रेजेंटेशन व्यू भी नहीं आ रहा ना, ये आ रहा है ना. प्रेजेंटेशन व्यू भी तो नहीं आ रहा. तो चलो पहले वीडियो लगा दो. ठीक है, मैं कर लूँगा. So in cataract surgery, because having your IOL well positioned, well centered is the most important thing, and for the patient satisfaction. And many times we are not sure because we go into the ill-judged landing of the IOL into the capsular bag. So this is the first case, and as you can see, the IOL, one of the haptic is stuck at the capsular edge. The one haptic is gone inside. So what to do in this situation? Very simple manipulation of this IOL can bring out. And what I'm trying to do is just trying to rotate the IOL. And once you rotate, free this haptic from the capsular bag, like especially because this was all adhered. The vent ahead, the vent and the IOL was finally implanted into the capsular bag. So this second situation, as you can see, this is the trifocal IOL, what Professor Titel was showing just now, because now this IOL is completely decentered and dislocated. One of the haptic is in the bag, other haptic probably there seems to be a capsular tear or something, or dialysis of the capsule. So what I'm trying to do is, because a very simple method, either you have to do the exchange or you can reposition this IOL into the bag or over the bag. So I have taken out the haptic out of the bag and tried to bring it to the center, and then I finally found that the IOL has taken its position because the capsular bag is fibrous, so you have a support behind, and this is how I tried to bring it to the center and position this IOL at the center of the pupil, and you can see the IOL is well centered, and this patient post-op gained good vision, because although the refraction was not very accurate, but yes, patient was quite satisfied with -1 diopter for the distance.
Dr.
Another
Rajendra
case,
Dr. Rajendra Prasad, the previous case,
yeah,
how much was the duration of post-op, both the cases?
this was almost 2 to 3 months.
So This shows that even after 2-3 months, he could open the bag and lens was placed in the bag. In these cases, the duration is also very, very important. Sometimes the fibrosis can be much bigger. In plate haptic lenses, you still can open up, but if you have a non-plate haptic lenses where you saw the previous case where they have a open loop haptic, optic haptic junction gets fibrous with the capsule access margin, and it's very difficult to open sometimes.
But this particular case, because this is a plate haptic, so plate haptic generally won't fibrose that much as you have these C lobes and other lobes, and you can very simply slip it out of the capsular bag. So that is what the first case, and this is the second case, which. So the third case, and as you can see, the IOL is completely dislocated again. It's almost sinking into the vitreous cavity. So what should I do in this particular situation? So I'll just ask Professor Tityal what to do in this situation. I'll just show you a little remind it, and this is the IOL.
Yeah. Again, this is again an open loop haptic case. And seems to be a haptic outside the bag, in this case, one haptic maybe inside. That is how it is decentered. And again, I would like to dissect out the rhexis margin. You can see the fibrosis seen at around 3 o'clock or 4 o'clock area. Then we can just dissect out the viscoelastic, open the bag if possible. The fibrous area should be managed, which is at around 9:30 o'clock. And if you can open that, then lens can be nicely rotated inside the bag.
Yeah. So as you can see, one of the haptic is in the bag and the other haptic is almost sinking through the capsular tear what you have in the posterior capsule. So what I tried to do, oh my God, what happened? So what I did, as you can see here, I just trying to dissect with the viscoelastic first, and then I'm trying to bring this haptic anteriorly and just hook it and then dial it, and then taking it back into the position under the iris. And once I got it, and then I'm taking it on the anterior capsule now. So I got the whole IOL. The second haptic automatically came out of the torn capsule, and now this IOL, as you can see, well settled on the anterior capsule. So this is what we can do, because instead of exchange. Now this is another case. The patient underwent RK a few years back, and then underwent cataract surgery also. And this post-op, the refraction was quite inaccurate, and the patient was absolutely unhappy. So we had to do the exchange in this particular case. And the exchanging the IOL in post RK surgery is not that easy, because you have certain issues. But what I tried to do in this particular case, brought the IOL, hook the haptic, bring it on the anterior capsule, and then bring the another haptic over the anterior surface of the iris. And then you have to just hook out one of the haptic, because you want to be sure, like, the IOL has to be stable within the anterior chamber for when you cut the IOL, it should not flip, because if you are holding one of the haptic out, then you'll have a much stable positioning of the IOL. And then once you cut it, after cutting it, you have to use frequently viscoelastic to protect the endothelium in this situation. And then I am trying to pull and dial technique, because you just pull out one of the haptic and then you dial, because your IOL is cut now into two, and this is how you can bring out the IOL. Once the IOL is out, then you can replace it with an accurate power of the IOL, and this patient actually post-operatively gained very good vision without any refractive error. So the intersection is very important, because when you are entering, now this is the another case, you can see the IOL is completely opaque. Now the only way out in this particular situation was to explant this IOL and change it with another IOL. So again, created the main incision, and as you can see, you have to use frequently the viscoelastic. What I'm trying to do is bringing out one of the haptic, but in this particular case, what you could see is like what I've seen, there was a posterior capsular defect also, like there was a rupture underneath the IOL, and this was this area where this haptic is there, and still I'm trying to bring it out of the capsular bag, and I could do it. And then again, the same technique, you pull out one of the haptic, and you can see the posterior capsular defect here. There's a huge defect here. And then this time I'm holding the IOL with the another forceps and then cutting it into two. So always better to give a cut on the IOL, almost 2/3 of the IOL, and then again with the dial and pull out technique, so which is the simplest technique to explant an IOL. And this is the IOL which has come out, a completely opaque IOL, and then went ahead with the partial anterior vitrectomy through that capsular defect area. Now I'm putting the IOL because now, as you can see, the IOL implanting the IOL was the most difficult part in this particular case, but still I tried to put this IOL into the bag. So as you can see, that the leading haptic I just inserted into the bag, and then the next haptic also went into the bag. And finally, this IOL settled very well within the bag, because although you had a big capsular defect here, but the anterior capsule as well as the fornices were intact. So the IOL went into the bag properly, and this is how the post-op looked up, and this patient had a beautiful vision. So the safe landing is very important, because the IOL has to land up in the capsular bag properly, and this is you have to similarly, like when you are flying, you have to select your airlines properly, because the airlines which is going to land up properly.
Beautifully managed. Just one question, Dr. Rajendra Prasad. You showed two exchange of IOLs. One was a normal IOL, and other was an opaque IOL. Yeah. Is there a difference in the two IOLs when you are cutting and removing them?
No, there was no difference in the cutting.
Because sometimes these opaque IOLs are a little harder to cut compared to your standard IOLs. So you have to be a little more careful. Like you nicely held the IOL and cut. That got your balance and cutting the opaque IOL. While the previous IOL you didn't hold it, you could still cut it.
Yeah, because this second IOL, because there was a capsular defect, so I was trying much safe, like so that it doesn't flip inside and increase the defect which is already there in the capsular bag.
But beautifully shown that getting one haptic out and cutting and then rotating the one by one, an entire IOL comes out. Very beautiful technique, and people should practice that, because we do see a lot of opaque IOLs in future also, because so many millions of hydrophilic lenses have been put in the eye.
Yeah.
Yes, we have a question.
Yes, Professor. There was this post-RK patient in whom you had explanted the IOL from the bag because there was a refractive surprise probably. Why didn't you go in for a sulcoflex or some lens like that and correct the error? Instead of taking the whole lens out and causing so much trauma, we could have just gone in for a sulcoflex IOL or post pseudophakic correction complementary IOL, as they would like.
Yeah, there are many options actually, because you can go with the sulcoflex also, but then sulcoflex is not that safe also, because you have to be sure like your bag size is good, and and your anterior chamber depth is good. So all these parameters have to be seen with the circumflex. Yeah, it's important. So
Why I asked this was because it is any day far more less traumatic than excising that IOL and bringing it out.
Circumflex, if you go for a proper circumflex from Reina, it's very costly affair. And now we have the Indian company doing these pseudophakic lenses.
Yes.
That can be tried. I have tried a few patients, but for that you need to have a good stable IOL, as well as the sulcus should be free and
I
the
thought
space should be there.
In this particular case, it was quite stable. That's why I asked this
Yeah,
question.
you have options also.
yeah,
and
you have option. Yeah, definitely, because so I thought in this particular case this would be a better option.
And another thing, psychologically, that patient has already undergone RK, which means from the very beginning, that patient has been very, very adamant about being spectacle free. So in such case, I mean, that's the psychological background of the patient.
You have to change the psychology of these RK patients. What I do, all RK patients, I make them sit into my ray tracing technology. I do aberrometry analysis, tell them your cornea is totally aberrated. I show them first, then do a surgery, because they think they are normal. They could see better with the RK. Now you'll see better with the cataract surgery also.
True.
So we have to diagnose them properly, show them your cornea has 16 scars. See the picture here, optical zone is hardly 3 millimeter, and your your aberration profile is this. So they understand they may not get a good vision, and I can't put trifocal lens in your eye. I'll put a simple monofocal lens, which will give you a better option. So they do understand. We have to break the psychology in these patients. Post LASIK, yes, still if the cornea is good, you can still give them a good vision. Post LASIK, post SMILE patient.
True. Thank you, Professor.
Yeah, post RK actually, because your cornea is completely distorted, and secondly, like your IOL power calculation is not so accurate most of the time. This particular patient landed up with almost +5 diopter post-operatively, and then we had to do the complete recalculation and all. Then
The very calculation is a challenge.
yeah,
in
calculation is
addition
very.
to
We used the ASCRS calculation site, and then actually we did calculation with the other like Barrett also and ASCRS and few more calculators also, and we took out the largest size, the largest power, and added over that 2.5 diopter. Then this patient had a -0.5 diopter post-operatively with just hardly 0.75 cylinder.
True, sir. I think from 2025 AIOS, you'll have to have a separate session for handling cataract patients who have undergone refractive surgeries.
Yes.
Yeah, that's
Because
right.
all of those fellows who underwent refractive surgeries in 2000 to 2005
True.
have started developing cataract now.
True.